G'day everyone. Thank you for giving me a moment of your time and watching. Today I'm just going to have a little bit of a chat about osteoarthritis. Now, after being in clinic for 32 years, it never ceases to surprise me how often I'll get either a phone call or a text message from either a client on behalf of someone else asking me about, Stu, do you treat osteoarthritis? So my first question back to those people is yes and no. Okay, I'm sorry to be ambiguous, but for me, the first thing that I will be thinking about is, right, whereabouts is the arthritic change, and what are their symptoms? Okay, so if we keep in mind that we're all eventually going to develop osteoarthritis at some stage of our life if we live long enough. Some of us earlier, some of us later, depending on what we do in our life. Obviously, there's a hereditary component. So there's a lot of reasons of why we get osteoarthritis, whether it be early on or later. I'm not going to debate that. It just is what it is. It's an individual thing, and it affects people from all walks of life at different times, and depending on our physical activity of what we do in our occupation as opposed to our sedentary situation. So, there's lots of variable factors. So for me, when a client is asking me, do you treat arthritis? Yes, the first thing I say is yes, and I say no. And then the reason I say that is simply because I know most people are using and tagging their symptoms to osteoarthritis because there's a fair chance they've had some imaging, whether they've been to their GP or whatever the case, they've had an X-ray or an MRI or whatever the case. And what you'll probably find is, especially depending on the age they are, if they're over the age of 45 or 50, there's going to be some levels of change from a degenerative point of view. It is what it is. But it doesn't always mean that is their pain. And that's not to poo-poo anyone who's got arthritic pain. It's absolutely, there's no doubt about arthritic pain is real, but sometimes there can be other things underlying. There can be some more superficial things that can mimic arthritic pain. So just having the imaging doesn't necessarily mean that your pain is coming from the arthritis or the arthritic change in your spine. So for me, it's yes, well, there's got to be some subjective assessment about the symptomology. Is the pain giving you grief at night? Is it on movement? Is it triggered by, extension? Maybe there'd be some facet joint irritation involved because, let's face it, as we get older, our disc heights start to shrink. Okay, so we lose some disc height. When that happens, obviously the facet joints either side, especially in the lumbar spine and obviously cervical spine as well. As you lose that height, there'll be more pressure on those facet joints, and obviously that will create irritation to those facet joints. And that's usually the painful stage of those arthritic changes. So they sort of go through these pain years and then they just get really stiff because everything starts to fuse. So it depends on what level they're in, what grade of arthritic change. Are they mild, moderate, or quite severe? And is that fusion starting to happen? And I've certainly treated a lot of people through those painful stages because, look, there's plenty of things out there that people either take or they do for arthritic pain. But I think the main thing is, from a therapist point of view or from a soft tissue therapist point of view, and especially from my point of view, and that's what I'm putting forward, is I would always encourage clients to come in. Obviously, I'll do my subjective assessment, have a look at their range of movement and their function, and then I would trial treat them. Now, I can't change arthritis. I can't actually change what's happening arthritically. That's just it. No one can really. It's just part of evolution of growing older. But inevitably what will happen around an arthritic joint or arthritic areas is, there will be some changes from a soft tissue point of view. Normally they'll start to develop some latent trigger points because of the irritation in the area and so forth. And, God forbid they may develop to active trigger points. And those two worlds are completely different, a latent trigger point to an active trigger point. Latent is obviously just when you press it, and then obviously you can reproduce their pain. Active is obviously they're feeling it all the time, even resting pain, and then obviously on movement and so forth. So those two worlds are very different. Now, yes, I can change that. I can treat that area. There's no doubt about it. But it depends on how much of a change I get. So, for me, there's always three things that I've got to look at. Am I getting a therapeutic change, which will be, am I changing the intensity of their symptoms, the duration and the frequency? Okay, so if I'm hitting all three of those, then I know that I'm having a therapeutic change, and I could play a role in helping them with their arthritic condition. And I trial treat them, usually do 3 to 4 treatments, sometimes a little bit more, and see how they respond. Now, namely, if I was looking, let's say, for example, someone was coming in with, an osteoarthritic change in their lumbar spine. So my go-to muscles are going to be erector spinae muscles, quadratus lumborum, and the gluteal muscles. They're my three key areas I want to address, and I want to see what the tone's like. I want to see what the tension's like. Obviously, there's going to be a lot of palpation to try and reproduce some of their symptoms if we can. If we can, that's great. We trial treat those, and then we see how they respond. How much of a change are we making? So inevitably, there may be clients who are coming in who have a lot of soft tissue guarding, and a lot of their pain is derived from the soft tissue. So you will get a great change if that's the case. That's awesome. And people going, oh my God, yeah, you treated my my osteoarthritis. No, I didn't change. I didn't treat your osteoarthritis. All I did was make a change to some of the structures around that. The arthritis is still there, the change is still happening, but for whatever reasons, a lot of your pain actually wasn't coming from the arthritic joint itself. So that's a good result. And they're the people I'll get good results with, obviously, from a soft tissue point of view. You've got obviously other allied health practitioners, whether it be a chiropractor, osteopath, physio, whatever the case may be. They may do other sort of types of treatments, manual therapies, whatever the case, and they may also get changes, and that's great. I mean, I'm specifically about soft tissues. You may want to bring in other modalities, like dry needling sometimes works an absolute treat, sometimes it doesn't work on others. So there's this real trial sort of situation, and you need to keep in mind that if you are dealing with an arthritic change and you know that their pain's coming from there, then from a soft tissue point of view, how much of their symptoms is coming from their soft tissues? That should be your guiding light. So yes, to a certain degree, I can help treat arthritis and the symptomology of it, but no, I'm not changing the arthritic joint. I may be able to make it move and function a little bit because the secondary soft tissues have reacted to that arthritic joint. And then, once I've got those three key areas, working well and I feel good, then I will start to expand my treatment. I'll go out, obviously, look at, what's happening at the TFL muscles, more of the hip muscles, whether it be adductor magnus and the like, and try and open up the area as much as I can, feedback, maybe thoracic spine stuff, whatever the case. And you can expand that, and that's an individual process that you'll work out yourself. And then the other thing is the goal for you should always be obviously to get your clients moving and strong again. So once you've been able to take them out of those environments and maybe desensitize them from a soft tissue point of view, it should always be your goal to be referring them off or in conjunction with exercise physiotherapist or, exercise physiologist or essential strength and conditioning person that can help them start to get moving again and get strong. Because some of the things that we do see, say, from research is that the multifidi muscles will start to atrophy a little bit, and that's not a good situation. So we want them to be strong through those areas. But that's really difficult when they're in a lot of pain, and then obviously going into those movements create pain. And there comes the conundrum for a lot of people, and they get lost on this merry-go-round in regards to, yes, I want to get stronger, but me doing the exercises sometimes can flare my symptoms up. And I feel like I'm going nowhere. 2 steps forward, 1 step back, or 1 step forward and 2 steps back. So, and it depends on the person. So when we're looking at, treating, osteoarthritis or arthritic change in the spine, if we're looking at facet joint irritation, which is a really temperamental condition to treat, I've found over the years, it's the number one. It's just really highly temperamental. Remember that depending on what arthritic change they're going through and what time of their life, they may go through those pain years and then they'll get into those stiff years. So we want to try and get people moving and functioning and feeling better as long as we can with the tools that we have. But we've got to marry those tools and those outcomes up, one with our assessment and two with the outcomes that we get. Are we getting a therapeutic change? Are we reducing the intensity, the frequency, and at the end of the day, are we getting that therapeutic change? Intensity, frequency, and duration. They're the main three things. If we're hitting the mark on all three of those, then there's a fair chance we can help our clients deal with these osteoarthritic thingos. And, at the end of the day, their pain might not actually be coming from arthritis. It's just that they had the imaging, practitioner saw it, said, yep, your pain's coming from the arthritis, that's what it is, and lump you in that. And that's not always the case. We can grab people off the street who are non-symptomatic, imaging them, they'll have disc bulges, some arthritic change, but they actually don't have any back pain. So how do we account for the fact that they don't have any pain? So we know that. We know that imaging is great. It's amazing, especially if we want to rule things in and rule things out, but it's all got to marry up together. The assessment, symptomology, treatment, and the imaging, are they all marrying up together, and are we getting that change for our clients? All right, guys, I hope that's helps you a bit. I know most of you who are clinically driven, who are deep in the guts of clinic, you will see plenty of arthritic people, and this applies to arthritic shoulders, arthritic knees, ankles, whatever the case may be. You take your time, palpate, try and reproduce, work those soft tissues, see if you can get a change. As I said, from a therapeutic situation. And lo and behold, you never know what can happen, but it is purely an individual situation. Anyway, I hope that helps you be awesome at what you do. Carry on doing the good work. See you next time.